Get ready to know what you don't know about being body brilliant. This is the Medshield Movement Connect show, where we connect the dots between fitness, health, wellness, nutrition, and of course you. Hosted by me, Dr. Fez Mkhize, and a special guest that we have every month, sharing knowledge, insights, and groundbreaking tips on how to get fitter, be stronger, and live healthier. Turn up the volume and listen close. Today you amplify. It's the Medshield Movement Connect show. Let's go. Welcome back to another amazing episode of Medshield Movement Connect show with me, Dr. Fez. Now, I have gone through all sorts of specialities in my time as a doctor, but I really did fall in love with obstetrics and gynecology. And guess what? Today, we actually have a gynecologist coming down and sitting and speaking with us about all things women's health and things that even I need to know as a guy, Dr. Rubushe Ngwenya. Thank you so much for sitting down with us, Doc. Now, I always like to just start off these discussions with other health practitioners as to why it is they went into the medical space, and for you, why you chose this speciality.
Thank you for having me.
Sure.
It's very lovely to be here.
Yeah.
So for me, I'll say the cliche thing is I love pregnant women. I guess it didn't really start off like that.
I just love that
Because
statement. I love pregnant women.
I do. Funny enough, I'm more of a gynecologist. I am an obstetrician,
Okay.
but I do both. I
Yeah.
love both. I mean, I'll never stop doing obstetrics because that's how much I love it. But I do more gynae.
Sure.
But I got into the speciality because I love the complexity of it.
Mhm.
You know, we've got the well patient who comes in and you take her through the journey
Mm.
and she delivers and she goes home. Life is done. Then if you're saying, no, I'm a little bit more medical, I need a little bit of a challenge, then you have the patient who comes in, she's pregnant, but she's got diabetes, she's got hypertension, she's got all the other medical conditions that you can then manage,
Yeah.
together with the pregnancy. And and then so you've got that part, and then you've got the gynecology part, which is a whole host of like speciality on its own.
Yeah.
Some people even say, Guti, why is it even put together? But I mean, you've got the oncology part when you've got patients with like, cervical cancer and all of those. Yes, it will more be on the gynae oncology people who would manage it, but you still have that. You've got a patient with like your menstrual disorders. So it's a whole host of things. And then my love is the theater part.
Surgical.
Yes, it's a surgical component of it. I love being in theater. I love being able to, find a problem, cut it out. And so the mix of the obstetrics and the gynecology and the ability to do a whole range of things, it's never boring. It's never monotonous. Well, some people who say if you do one part of it, it might be, but the whole host of it that comes together. And I mean, my special interest being infertility.
Sure.
It's such a fulfilling thing when you get a woman who comes in, unable to fall pregnant, unable to have kids. You do everything that you can, and then eventually they go home with a baby in their hands. It's a very emotionally fulfilling, speciality. So for me, it's all those components put together, and I don't think I'd ever do anything else besides obs and gynae.
And clearly, you're somebody who loves complex things in life. You're not somebody who's very kind of one-dimensional. All of these things that you've described, and you're right. It's also why I always felt obstetrics and gynecology was very tough. It was very tough because there's a lot of things you have to kind of get right, but there's also the precious life that you're helping to bring into this world, especially from the obstetric side. Now, you say that you had a great intern in your time who rotated through obstetrics and gynecology. Could you just tell me about your experience with said intern?
So the said
on record.
intern, I can't remember where I'm putting. I'm
Yeah.
joking.
Yeah.
No, it was when you rotated through at Charlotte McClacken.
Yes.
Yes, one of my
Yes.
interns rotated through. It was a good
Experience. Just the experience. I was a lot of energy. It was
Good energy.
no
Big,
lying, but also maybe a little lying just on camera.
good energy. On top of his game. Um, very, very thorough. I mean, I can't remember that I had an issue to say, stuff is not done or patient not followed up or anything like that. Yeah, I mean, very charming though, I must also say, I mean, flashes a smile way too many times. Okay. Kind of try to get things done that way. But all in all, a good experience.
Healthcare needs to be given, and it must be given with a smile. But
100%.
already, I mean, just sitting with you, people could probably tell at home you're somebody who likes not just one-dimensional things, as I said, you're quite complex. But could you tell me when it was you wanted to do medicine? Because speciality is one thing, because you do medicine, you rotate through, you see all the things that you like. But what is it at the root of why you like to help people?
Funny enough, I actually wanted to do medicine. I chose my subjects. You know, when you choose your subjects in grade 10. Grade 10. I chose my subjects because I wanted to do medicine. I don't know, it was just my environment that made me feel like that's what I want to go into. But, when I was trying to get into medicine, obviously coming from rural Eastern Cape and my parents not having a good, strong financial part to be able to put me through medicine, they told me straight, we want you to be a doctor, but we don't have the finances. And so I sat down and I put in the work. And I actually got a full scholarship, not a bursary.
And I'm not surprised. I know I'm going like this. I'm more like, I mean, obviously.
Yeah. I actually, not even a bursary, I got a full scholarship to study medicine. And that's, that's how I got in. Yeah. And funny enough, I only applied to 3 places.
Okay.
UCT, Wits, and then Medunsa. And I think I'm still in the waiting list for UCT. Because I think when I called in March, they were like, "Oh no, sorry, you're still in the waiting list." I'm like, "Really?"
Wow, that's a bit of a delayed reaction. If I've ever heard.
No, but Wits responded, so I was already in the program at Wits, but I was just like, "Let me just check." They were like, "No, you're still in the waiting list." I'm like, "Oh, it's March, guys."
The system.
Yeah.
Oddly enough, I only applied to one place for one thing because I was naive. And that goodness, the universe was like, listen, you're a very hopeful child. We'll get you in on that one thing that you wanted. But for me, I think just listening to you and the descriptions you're giving and the fact that you went into infertility, I know how difficult of a space that is. So you're not just competent from a cognitive perspective. You clearly are somebody who's also emotionally aware, because when you step into that space, it can be quite heavy, but you seem to be somebody who's very light. You're somebody who's very upbeat. Could you tell me some of the difficulties when it comes to being within the infertility space? Because there's already an issue when you're coming in, so you're going to have to work through that.
Right. So I'm not yet a fertility specialist. I'm an aspiring one.
Sure.
But I do run the endocrine and infertility clinic at Baragwanath Hospital. And I also am part of the team that runs the obstetric history. So those are two very emotionally heavy clinics, because in those clinics we run into ladies who either are unable to fall pregnant at all. And so, I mean, society detects that if I'm a woman and I'm a certain age and I'm married, they expect an offspring. I'm expected to produce children. And so when you're unable to do that, it's very heavy, emotionally. And for somebody who tries at a very earlier age, and then by the time they get to me, 40 years, 42 years, 43 years, and always my question is like, where were you? And I mean, not taking away from anything traditional, and not taking away from the fact that yes, we're Black, and we want to explore all other avenues. There's a lot of women who get delayed by that. They have a conversation with somebody who says, "Oh no, keep trying, you'll be fine," and then their 20s go by. And then their 30s go by, and by the time that I'm looking at you and your ovarian reserve is like on the floor, it's difficult, and then you talk about IVF and the cost implications related to that. It's very difficult, and so these women sometimes don't have a lot of emotional support, around them, because now they're experiencing this thing alone, and everyone is just looking to them so that they can have babies, and then similarly to the ladies who have recurrent miscarriages, who are able to fall pregnant, but they keep losing those pregnancies. And now you have somebody who's been pregnant 7 times and they don't have a live baby. It's very emotionally heavy, those clinics. But I love doing those clinics, you know. I love being able to help those women
Yeah.
as much as I can. And yes, you say I'm a bad human being, but this is me on the baseline. You know, I walk into work like this. Anyone who knows me will tell you, Guti, I approach my patients like this. Doesn't matter where I'm working. Yes, I work a little bit of private, you know, and I also work primarily at Barra, but this is me all the time, and I want them to know that we try.
Sure.
You know, we try, we do as much as we can. I mean, if we have to take it as far as we can, because yes, at Barra we don't have full blown services in terms of reproduction, but there's places where we send our patients to. Like we'll send our patients to Charlotte Matleke, where they've got a unit now that's coming together. I send them to Steve Biko, and I've fostered all those relationships with those different hospitals so that we can be able to help our women as much as we can. But yeah, but it is very heavy emotionally, but I still like to do it.
I love how intentional it is when it comes to you stepping into that space, and I think it's a match in my mind, just from your energies. On the show, we like to connect dots for people. We always like to simplify things as best as we can. And you speak about people who wait a bit too long to actually come and see somebody.
Yeah,
And that kind of that reserve depletes the ability for you to kind of have eggs. And then, yeah.
yes.
When would you say people should start thinking, maybe I should see somebody? Because it is not something that said, okay, if you've been trying for 2 years, go, or 5 years. What are some of the trigger points where you're like, okay, I should see somebody? And even then, how is that journey when it comes to somebody who comes in quite late stage? When is it where you go, okay, maybe we've gone past the mark? So what are those age ranges?
So basically we define infertility as a year of unprotected sexual intercourse with intention. So obviously no contraception, all of that stuff. So you've been actively trying to make a baby for a full year and it hasn't happened. That's when you should intervene and come to the doctor. Okay. And but if you've got a known gynecological issue, okay, we reduce that down to about 6 months.
Okay.
All right. And if you're over the age of 35, we also reduce that. But there are some instances where, like if you've got like known endometriosis, or you've got PCOS, or you've got anything, you know, or you've got fibroids or anything like that, then we would say go to the doctor immediately.
Sure.
So let's say you made a diagnosis in your early 20s, you know, and now you've been sitting around because you're not ready to have a baby. The minute you want to say, okay, fine, I want to try, go immediately. You know, maybe you can start trying. I mean, don't not try. Try naturally, but go to the doctor. Go be assessed and see, okay, are my fibroids, have they grown too much that they are sitting in a place where they can cause infertility? Or where's my PCOS sitting, you know? Or how bad is my endometriosis? Okay. So so definitely if you've been trying regularly for a year, you have to go and see a doctor so that they can then intervene in that space to say, okay, fine, let's do the workup. Let's see exactly where the problem is. All right. And then the other thing is that we as women are now very career driven.
Yep.
So the truth of the matter is, whereas our grandmothers were having babies in the early 20s, we having our babies mid to late 30s, and maybe sometimes pushing it to 40.
I mean, also discussions around, I know friends who've had their eggs and they've kind of frozen.
Yes. So that's where the point of contact, I'm trying to say, is that go get an assessment done and maybe go freeze your eggs. Okay. It's better for you to go in and get your eggs frozen and get a lot of eggs out when you're still young and you know you've got security. And then live your life, and then when you're ready to make a baby, go do IVF at the age of whatever you want to then do it at a later stage. But then you're guaranteed, or well, maybe, okay, nothing's written on stone, but you have some guarantee that you've got fresh eggs that you can be able to use, you know, and that you can be able to do IVF on. So yeah, so that's what I would then say, you know. So when you then start moving past your 40s, egg retrieval and being able to have good eggs that are going to then equal to a baby, it becomes less and less. I know it's always a thing to say, I can have a child whenever I want because, you know, I can make it. It's okay. I mean, we can have those conversations because yes, you can have a child whenever you want, But the truth of the matter is that your ovaries are aging with you.
Yeah.
Because with a woman you are born
With the
with
set number.
every set, the exact set number of eggs that we're always going to have for the rest of your life. So you can't make new eggs. So that's why you then say, okay, fine, if you identified that this is the career path you're taking and you want to have kids later on stage, that's okay. You can. But just freeze your eggs so that you have the ability to have the kids when you want. And you can have DNA, you know. There's nothing wrong with using donor eggs because I know that people do donate. But there's some people who say, I remember I was having a conversation with one of the ladies, like in my clinic. She was over the age of 42 and she wanted to have a baby. And she says she's willing to go to private. Can I, advise her how it works and everything else? So I was talking to her and advising her and was telling her how the whole thing works. And the minute I mentioned donor egg, she's like, wait, hold on. So you mean that somebody else is going to produce an egg that's going to be put together with my husband's sperm? And then, yes, I grow that, but that child is not. I was like, yeah, she's like, yeah, no, sure.
Yeah.
No, it's okay. I'll adopt.
Yeah. Definitely a difficult conversation, I think.
It is a difficult conversation. So, I mean, don't wait too long. That's what I always say. I don't think we educate our couples enough, because remember, infertility is a couples thing. It's both the man and the female who come together and they have an inability to make a baby. Okay. And so that's why, yes, my point of contact will always be the woman because I'm a gynecologist. But we always try and foster that relationship to say, bring your partner in, because part of the surveillance that we do, yes, we work up the woman to see where the infertility could be. But we also do semen analysis, as a screening tool for the man to say, okay, fine, are you producing sperm? Is it normal amount of sperm? And can that sperm then translate to an offspring? Okay. So if you're struggling, please, come in immediately. Don't wait much longer, especially in your older years.
And there you have it. It is clearly a very complex speciality, but I also love the fact that you bring that human element. And to be honest with you, I always tell people it takes two to tango. So don't just look at one side. You've got to make sure both sides are balanced out. I wish we could be speaking about more things, which is why I'm saying we're going to have you on another episode, because this is probably just the tip of the iceberg when we're talking about fertility and infertility, yet alone a whole host of other gynecological issues that you might be able to expand with us. But it is Medshield Movement Connect show. Dots have been connected. The take-home message here today is make sure you come early and you have somebody who you can trust, ideally, who knows what they're talking about to help you along that journey. And remember, that 1 year mark, if you're trying, not hitting it, make sure you come in. And if there are any other issues, 6 months or even earlier, go see your doctor. But that's me, Dr. Fair, signing out on another awesome episode. See you soon.